Oh, pathophysiology students, this lecture is going to go over some renal disorders, or as we say, kidney disorders, beginning with congenital developmental abnormalities, some abnormalities with filtration, which are going to involve the glomerulus, and then we'll talk about infections of the various levels of the tract, which is also going to lead us into stone development. And then, like every chapter, we end with the failure state of that organ. So we'll talk about renal failure and then also dialysis. So when we think about developmental abnormalities, I want you to have a little bit of an understanding of the way these tissues develop. They are part of the germ layers referred to as the mesoderm, and these develop in the pelvis really early on. Really, in the first trimester is when all of the organs and other parts are developing. And throughout development, they do ascend into their final position, which we know is right behind, peeking out of the bottom ribs. There's three main congenital abnormalities. So one is going to be renal agenesis, so the lack of creation. So that means they were not developed. A means without, and genesis is creation. So renal non-creation. If that is bilateral, that is what we call incompatible with life. That would mean both kidneys fail to create themselves. So that's not going to lead to compatibility with life, because any waste products that need to be removed are not going to be removed, ideally through the bloodstream. Whereas unilateral agenesis is really interesting because it's a common disorder. It's asymptomatic, meaning that there are no symptoms of having only one kidney. Because the kidneys are so good at regeneration and more of a stable slash labile function, the remaining kidney undergoes hypertrophy so that it is big enough to take on the role of two kidneys. So generally, people don't know that there is an abnormality until they have a CT scan of the abdomen, and then they're told they have one kidney. Then we'll see that there is duplications of the urinary tract. So we'll talk about the ureters. You'll see this on the next slide. The ureters are connecting the kidneys to the bladder. So if this is a kidney, we have the ureter here, and then we have this area here called the renal pelvis. So that would be a duplication. That's a complete duplication. And then there's incomplete duplications where there is just a duplicated upper part. Again, you'll see that on the next slide. Then we have these weird malpositions where one or both kidneys are going to be in an abnormal location. So let's take a look at that. So first off, we have, let's go back to blue. Here's our normal creation. Again, from the mesoderm layer, both kidneys are going to migrate upwards to land in their final position. Here we have unilateral agenesis. So on one side, there's a lack of a kidney. So there's nothing over here. And again, this is asymptomatic. So I'm just going to make a minus. There's no symptoms here because this remaining kidney will undergo hypertrophy until it's big enough to take on the function of the missing kidney as well. There is duplication of the tract. So that's what you see on this side. This kidney has two ureters with it. Do you think that there would be any abnormalities in function from having two complete ureters? This is another thing with complete duplication. We don't see any symptoms with this. However, in this congenital abnormality called premature splitting, instead, oh no, I lost my marker. Instead of having two complete ureters, there's a premature splitting of the ureters. So it makes a Y shape. And the problem with this, so we had no symptoms, no symptoms. This is going to have symptoms associated with it because the rule with urine is that it is sterile as long as it's moving. And we'll add one more thing to that. It has to be moving in the correct direction. When it stagnates, that's when you pick up bacteria and you see infection. So with premature splitting, you'll see filtrate flow down here, and then it can flow back up to the kidneys, causing kidney infections. And individuals find out that they have this type of abnormality when there's repeated kidney infections. Okay, then there's failure to ascend, so the kidney arises and it doesn't end up in the right spot. This is another abnormality we wouldn't consider really to be symptomatic. It's just in a little bit of a weird place. There might be some, the pain would be different when we talk about kidney infections if it is not in its normal location, but generally it's asymptomatic. This is a really fun one. Pathologists love the horseshoe kidney. This is when the lower poles, so each of these kidneys would separate here and then go up to their normal position. Here, they fail to separate, so it takes on the shape of a horseshoe. Horseshoe kidney in and of itself is not truly symptomatic. However, it does tend to co-occur with premature splitting. So the only way you would have symptoms from this is if there is that premature splitting and that Y-shaped ureter because of that. So we would say this is generally asymptomatic unless there's premature splitting, which is common with it. So it could be symptomatic or asymptomatic. This is one where the kidneys just did a poor job splitting instead of them going from the lower pole out. The upper pole of the kidneys on one attaches to the lower pole on the other. And so it's one kidney. Again, there's no real abnormalities with this that would cause any physiologic symptoms unless there's that premature splitting of the tract. So those are your congenital abnormalities. The one that's really important with creating physiologic abnormalities is this premature splitting. And when we do have these abnormalities down here where there's fusion, they do tend to co-occur with this. And this is the one that's going to drive symptomology. All right, so this is starting off with just showing you how many different things can happen at the level of the glomerulus. So there can be inflammation of the glomerulus. We call that acute glomerulonephritis. There's membranous glomerulonephritis. There's mesangial deposits. There's a lot of things that can happen in this area. Proliferative glomerulonephritis is something you see in lupus. The whole point of this is because the glomerulus acts like a strainer. When there is damage to the glomerulus, there's going to be damage to filtration. So no matter what you call it or what caused it, you will see things leaving the urine that normally shouldn't leave. So what we see most of the time is this is something that begins because of this type 3 hypersensitivity, where you get these small buildups of antibody-antigen complexes. And they're so small that they don't get carried away in the bloodstream, so they can get lodged. In a place where they get lodged really commonly is in the microcirculation. And remember, the body, whenever it sees an antibody, it's going to attack whatever it's attached to. So an immune cell would see if we're inside of a capillary right now, which would be inside of the glomerulus. It sees antibody, it sees it on the endothelial wall, so now it's going to start destroying this tissue. And then you will see that different cells, mesangial cells, leukocyte cells, they're going to activate this pathogenesis so that we have immune destruction, and then it starts punching holes in the wall. You'll see clot formation. We call the microthrombi because the basement membrane's exposed, so therefore platelets are going to bind to the exposed basement membrane, and it all begins because of this immune complex damage. So when you have antigen development to bacteria, this is really common with strep throat, where there's a huge amount of antibody created, and even more so when people have recurrent infections with different disorders. You get this immune-mediated damage. That's called the type 3 hypersensitivity. It's too much immunity. 70% of cases of glomerular damage are because of this type 3 hypersensitivity. And just as I walked you through the complement cascade and phagocytic cells, they activate destructive proteases, you get free radical formation, you expose the basement membrane, and then you damage that area, getting microthrombi and getting, frankly, just really big holes in the capillaries of the glomerulus, which means that now big things can fit through there instead of just water and electrolytes. This is just a picture from an older textbook showing you a close-up of a glomerular capillary. We see some little clots forming here, and we see these phagocytic cells then responding to that and then starting to damage the basement membrane. This is what this looks like in real life, and we also refer to this as hyalinization. Okay, so different types of glomerular disorders. There's one syndrome called nephrotic syndrome. I would like you to remember that the O in nephrotic should remind you that that means protein. Nephrotic syndrome is when there's so much damage to the glomerulus that protein is lost in the urine. So one of the big symptoms here is proteinuria. And you can check for proteinuria with a dipstick. You can also see it really easily because it looks like somebody has put dish soap into the urine cup and then peed into it. So protein-rich urine is really, really frothy. But you definitely test it to confirm with a dipstick. When you're losing protein, so that would be your main like plasma protein, which is albumin, your body can't just make more albumin, unfortunately. What that means is you're going to lose the oncotic pressure that keeps fluid in vessels. So the way that this works is called the Donin effect. Proteins are negatively charged, whereas the elements of the plasma are positively charged. And negative and positive, they attract one another. So if there's holes in this capillary and then proteins are allowed to escape out through the urine, well, what attraction is there for the elements of the plasma to stay there? Well, there isn't one. So that's when you see fluid leaving the circulation and then ending up in different places. So this could be total edema, which is throughout the entire body. There's ascites, like you see in this child. That's when fluid fills the abdominal cavity, or it can fill the thoracic cavity as well. That's called hydrothorax. And when kids have nephrotic syndrome, so like this individual, this is from untreated strep throat. Again, there's a huge amount of antibody production, and then there's destruction of the glomerulus, and you see ascites. Kids recover really well from this, whereas adults, they unfortunately progress to more severe and chronic forms of renal disease. And so this is the whole syndrome for you. It begins with glomerular damage. The main symptom here is proteinuria. So you lose protein, and it's in the urine. We call that proteinuria. The protein that we're losing is albumin. So that's hypoalbuminemia, low albumin in the blood. As I said, the body can't just make more albumin, but what it can do is make LDL. That's what you see here, lipoprotein. And LDLs are bad cholesterol. So you see high LDL because the body is trying to maintain the normal protein levels. Again, when you don't have adequate protein in the bloodstream, that messes up the osmotic pressure, and then the fluid leaves the vessels. You'll see edema, and you're going to see things like ascites or hydrothorax as well. Okay. Even worse, we have nephritic syndrome. We said nephrotic, the O should tip you off that it's protein loss. In nephritic syndrome, the problem is also going to be not just are we going to have proteinuria, the main problem here is hematuria, blood in the urine. This also begins because of just inflammatory changes. Any kind of damage to the glomerulus, 70% of the time has to do with that antigen-antibody complex damage. So we see blood in the urine, hematuria, erythrocytes are red blood cells, they leave the circulation, and then the way that the body couples with this is that it reduces the rate at which we filter our products to try to save blood. When the blood is being lost, the blood pressure goes down, so the body will send out signals to lower the rate of filtration and the force of filtration so that we maintain our fluid balance and don't get into shock. So you'll see oliguria, which is decreased urine output. Azotemia is the buildup of nitrogenous wastes in the bloodstream because we're not removing the waste products we need. And then fluid retention in all glomerular disorders, you will see that because there is an alteration to plasma volume caused by protein loss. So the extra fluid will not be peed out in the urine as we would expect it to. Instead, we see that that fluid is retained. Okay, just really quickly, we know scler means hardening of vessels. There's a bunch of different things that can go wrong with the renal arteries, and a lot of it is truly just because of the anatomy of the system. The aorta is the largest pressure artery in the body, and it goes unimpeded from the left side of the heart all the way down the cavity. And the first place it bifurcates or splits in two is down here at the renal arteries. So highest pressure, highest velocity, and then the blood is going to have to make a 90-degree turn essentially to get into the kidneys. We know that the faster the shear, the more likely it is to have turbulent flow or swirling of the blood. So that's going to break down the wall. We get basement membrane exposure. So not only can there be scarring in that area or clotting, you also see fatty changes to the vessels so that we have fat accumulation with inside cells, and that's called nephrosclerosis. That's what you're seeing here, malignant nephrosclerosis. When there is so much damage to the arteriolar portions, you can get a lot of thickening leading to ischemia, and you get portions of necrosis of the kidney because ischemia is referring to a lack of oxygen. You get this thickening because of high blood pressure. So the higher the pressure, the higher the velocity, the more of a likelihood of damage to the renal arteries. So you see this mainly with severe hypertension. In benign cases of nephrosclerosis, the renal arteries themselves are not damaged that badly. So there's still going to be adequate blood flow to the kidneys, minimal excessive uration, maybe some filtration abnormalities because of changes to pressure. Whereas malignant, like you see here, there is almost a complete lack of renal artery blood flow. So this is something that would lead to renal failure because inside of the vessel itself, you see a lack of lumen. And we know lumen is the inside of a vessel. So if you don't have an inside of a vessel, you're not going to have enough blood flow. The kidneys start to atrophy. They're not going to do the things they need to do, like excrete waste, excrete acids. So you'll see things like acidosis, and then you'll definitely see a loss of all of these elements. Hematuria, proteinuria, and death due to renal insufficiency is possible if there's not a dialysis or donor organ plan. You see damage to the kidneys a lot with diabetes because diabetes goes along together with high blood pressure. That's kind of a rule. The largest cause of death in diabetes is an infarct due to hypertension, to atherosclerosis. So in diabetes, there not only is really high blood pressure, so high BP, you also see that there is an overuse of the kidneys. So you know with diabetes, they're urinating a lot. There's excessive drinking, excessive urination. The more you use something, the more likely it is to be damaged. If you drive your car every day, 100 miles a day, it's more likely to get wear and tear than a car that you drive twice a week. The symptoms of diabetic nephropathy, which means disease of the kidneys, you get progressive renal impairment, which can progress to failure. You can see nephrotic syndrome, and there's not real specific treatment for it because it's a complication of diabetes. That means the treatment for it is going to target diabetes itself. So you see this with nephrosclerosis, that depositing of fat essentially in the renal arteries, and then that causes hardening. Okay, I will make a separate lecture for infections.